And we're going to talk about understanding and preventing vascular dementia. This is the one dementia that we know for sure we have some control over vascular dementia. So, first, let's go in and just identify and define what is vascular dementia. It's exactly what it sounds like if you think about it: vascular, cardiovascular. So, what then causes the dementia? It's whenever there's a reduction in blood flow to different areas of the brain and it deprives the area of the brain of oxygen and nutrients. So then we're going to look at what would make that happen, what would cause that to happen, and how can we stop it from happening? Or what are some things that we can do to lower our risk of this happening? Because when we have an inadequate blood flow to the brain, eventually there's going to be damage. And where there's damage, those cells begin to die. Again, if you've been on our programs before, if you have watched our YouTube channel, and if you haven't, please go to YouTube, put in our full name, James L. West Center for Dementia Care. There's dozens of videos on there. This one will be on by tomorrow. You can share it with other people. With dementia, all dementias, the brain is beginning to atrophy for different reasons. But with vascular dementia, the reason the brain begins to atrophy is because the brain cells are dying from deprivation of oxygen and nutrients. This is one of the few dementias that can come on suddenly. Most dementias, as you educate yourself, you're going to look back and go, oh, wow, that was showing up years ago. Because the more education you get, you realize there's so much more to dementia than memory loss. But with vascular dementia, it can come on suddenly, usually because of a stroke. Because a stroke blocks those blood vessels in the brain, and after the stroke, immediately after, and then we're going to again look at statistics, then the vascular dementia shows up. So, continuing with exactly what is vascular dementia, it can be very, very mild, and then it worsens over time because the person who has vascular dementia may be having, sometimes not even knowing it, you may not know it either, they may be having multiple minor strokes, teeny tiny. Sometimes they are pinpoint strokes called TIAs, transient ischemic attacks, TIAs. There are other conditions that affect small blood vessels. We're going to look at three different types of conditions that affect the blood vessels in the brain, and this is all directly related to the heart. We're going to talk about multi-infarct dementia, but it can be caused by anything, and I cannot stress that enough, anything that affects the cardiovascular system. So let's look at the top things that we know affect our heart health. Diabetes, and we know that we have some control over diabetes. Smoking, we most definitely have control over whether we smoke or not. Hypertension or high blood pressure, we have some control over that. High cholesterol, even if you have the type that is genetic, we have medications for cholesterol now. Obesity, we have some control over that. Depression, even in treatment resistant depression, we can treat symptoms. And sleep apnea. Now, some of you may be surprised to see something like depression and sleep apnea on the list of what leads to vascular dementia, and we're going to take a deeper dive into that today. But think about what's happening with depression. Long-term depression that is not treated changes the brain chemicals, and it can permanently change the brain chemicals. Sleep apnea, think about what's happening. Apnea, stop breathing. And if we stop breathing, even if it's for short periods of time, but it's for dozens of short periods of time every night, what's happening when we don't breathe? We're cutting off oxygenated blood flow to the brain. And over time, it leads up to vascular dementia. Lots of research on this now. Oftentimes, vascular dementia will coexist with another dementia. In other words, we're diagnosed with Alzheimer's and vascular. We're diagnosed with Lewy body and vascular. That is called mixed dementia. A person is diagnosed with two types of dementia, mixed dementia. About 80% of the time, that other dementia is vascular. There's some research, there are some studies that suggest that about 80% of people with dementia also have vascular. They may not even know it, they may not be diagnosed with it. Because if looking back over that person's life, there has been alcoholism, smoking, diabetes, high blood pressure, high cholesterol, obesity, any of those things that we just talked about earlier that were untreated, sleep apnea, it can then show up as vascular dementia later. It says here again, it often coexists with depression. And these cognitive symptoms can develop gradually because that chronic underlying problem is a blood vessel problem, like a diabetes or a high blood pressure. Those slowly narrow those blood vessels. So then progressively over time, the brain is being deprived of oxygen. So then we see subtle changes. Let's start with a short video about what is vascular dementia. And Jamie, make sure you can hear this, please.
What is vascular dementia? Vascular dementia is the second most common type of dementia. It is caused by problems with the blood supply to the brain. Nerve cells require oxygen and nutrients to survive. Without them, they will become damaged or die. Cells are provided with oxygen and nutrients by a network of blood vessels in the brain. When the blood supply to the brain is interrupted, for example by a sudden blockage, this is called a stroke. A stroke can cause significant damage to parts of the brain. When the parts of the brain responsible for memory, thinking, or language are damaged in this way, a person will have difficulty remembering things, thinking, or speaking. These are all symptoms of vascular dementia. Sometimes, a single large stroke is enough to cause the symptoms of dementia. This is known as post-stroke dementia. This scan shows damage to the brain of someone with post-stroke dementia. In other cases, a person may experience a series of smaller strokes that gradually cause damage. This is known as multi-infarct dementia. Following a stroke, a person's symptoms may remain constant for a while. Then, if the person has another stroke, they may notice a sudden worsening of symptoms. This is known as a step-like progression. Small vessel disease is where there is a narrowing of the blood vessels deep in the brain. Small vessel disease is the most common cause of vascular dementia. As the narrowing affects more small blood vessels and more of the brain becomes damaged, the person will experience a gradual loss of abilities. Usually, people with small vessel disease notice a slowing of thinking and problem solving. For example, taking longer to think of a word and write it down. Evidence suggests that lifestyle factors that promote a healthy blood supply, such as regular exercise, not smoking, and eating a healthy diet, could help to reduce the risk of vascular dementia. There is currently no cure for vascular dementia. However, by controlling underlying cardiovascular diseases which affect the blood supply, such as high blood pressure, high cholesterol, and heart disease, it may be possible to slow down the progression of the condition. Vascular dementia will affect people differently, depending on the parts of the brain that are affected. However, a common symptom is having problems with planning and organizing, or with concentrating. It can help to break complex tasks down into smaller steps and to make sure that environments are not too busy or noisy.
Excellent
What it
summary of vascular dementia. So, some of those statistics, it's the second most common type of dementia behind Alzheimer's disease. Alzheimer's disease is the most common type of dementia in people over the age of 65. Just in the last couple of years, frontotemporal dementia is the most common type of dementia in people under the age of 65. Now, this is a new statistic that 15% of all dementia cases are pure vascular dementia. That's all it is vascular. But there's another 16% on top of that 15 that's mixed. 20% of people who suffer a stroke will develop vascular dementia within 6 months. So make sure that you hear that. Not everyone who has a stroke is going to develop vascular dementia. Not everyone who has a stroke is going to develop vascular dementia. Does it put them at a higher risk? Of course it does, but not everyone will. The increased presence of cardiovascular disease is what puts a person at a higher risk. And then this last box here, the extent of the brain damage influences the severity of dementia symptoms. And we're actually going to look at some scans so that we get a really good idea of why one person may have these expressions and another person may have these expressions. So some of the symptoms that we may see in someone with vascular dementia. And again, there is a big umbrella called dementia. There's many, many different types of dementia. You can see these same symptoms in Alzheimer's, Lewy body, frontotemporal, different types of dementia, but this is what we tend to see in vascular. Now, again, that very first bullet point, it's going to vary widely depending on where the brain damage is, what part of the brain is affected, and how severe the blood vessel damage is. Memory loss may or may not be a significant early symptom. In some people, it is. In others, it may be really mild memory loss. That's why people can go undiagnosed for a long period of time. And especially if you don't work in the healthcare field, you may just be, well, that's cardiac issues. They've had cardiac issues, and you're not even making the relation between the heart and the brain because we're thinking, well, it's high blood pressure, it's cholesterol, it's diabetes, because we're not seeing those changes because it's subtle as far as memory goes. Or we may think that memory loss is age related. And then we come on a program like this, we start to get educated and find out we're not supposed to have any memory loss, not any real memory loss. We're going to slow down. I'm going to lose my keys. I'm going to lose my car in the parking lot. That's common as I get older. But actual memory loss is not a normal part of aging. So, some things that we can see with vascular dementia as far as thinking and cognitive symptoms. The video mentioned difficulty in planning and organizing, difficulty in paying bills. Maybe someone doesn't pay some of the bills and they pay other bills more than once. Having a really hard time focusing or being able to switch tasks, making poor decisions in someone who really has never made poor decisions, or they're having a really hard time making decisions. And this can be something as simple as handing them a menu in a restaurant, and it's just like it's too much. Can't make a decision. And again, the memory problems are often milder at first in a person with vascular dementia. But what you may see is it's like they're just slowing down, like their thinking is just a little bit slower because it's taking them some time to process. Now, we can also see vascular dementia show up in movement and physical symptoms. Things like their gait is off, they're unsteady, there's balance issues, there's just slower movements altogether. If there have been strokes, actual strokes, and we're going to talk about different types of strokes, or the TIAs, the little small strokes, we could have weakness on one side. Another thing that's common in a person with vascular dementia is that urinary incontinence earlier. With all dementias, the urinary incontinence and even bowel incontinence is going to come, but it's usually later. In vascular dementia, sometimes we see that urgency or the actual incontinence a little bit earlier. Some other symptoms, some that are a little more specific to vascular, the confusion, the disorientation, issues with communication, having a hard time finding words. Now, please don't panic if you find yourself going, what is that word? Hold on a minute, it'll come to me. Part of that is normal aging. This is actually not being able to find the word, never comes. You don't sit up in the middle of the night and there's the word like we would do with normal aging. Another one that I want to point out, we're actually going to watch a really short little video on one in this second bullet point here, is uncontrolled laughing and crying. You may have even seen commercials about this pseudo bulbar effect. And we're going to watch a little video again of what that can look like. It's sometimes called emotional incontinence. It's where somebody will laugh or cry at inappropriate times. It's fairly common with vascular dementia. And again, if you don't know about it, you don't know what you don't know. Having a hard time in social situations, not really understanding what to do, or possibly even doing things that are inappropriate. They'll remain stable for a time, and then there's a cardiovascular incident. And I don't know if you remember from the video, but again, you're going to get a copy of this. It showed Alzheimer's disease progressing like this, just kind of a slow, steady. But it showed vascular dementia plateau, drop off, plateau, drop off, almost like steps. And then there's some times, and then there's a drop off. And it's because of a cardiovascular incident. We're going to watch just a snippet of this next video so that you at least have an idea of what this pseudobulbar effect is. It's called an emotional mismatch. It's interesting.
Pseudobulbar affect, or PBA, is a medical condition that results in sudden and uncontrollable episodes of laughing, crying, or both. PBA is pronounced pseudobulbar affect. It's a disorder that affects some stroke survivors, as well as people with dementia, traumatic brain injury, Parkinson's disease, MS, or ALS. Sometimes a stroke can damage the areas of the brain that control normal expression of emotion, and a disconnection occurs, triggering episodes of uncontrollable crying and or laughing. While mood is how we feel emotionally inside, the term affect describes how we display our emotions to the outside world. In stroke survivors with PBA, mood and affect are disconnected. Healthcare professionals call this mood incongruent affect. PBA is sometimes called emotional incontinence. Just as a stroke survivor may lose control of his or her bladder, also known as incontinence, this condition refers to the inability to control the display of specific emotions. And just like incontinence, PBA can also be disrupting and frustrating. PBA episodes can be triggered by something that is only slightly sad or funny. For example, a funny commercial about puppy dogs may cause tears. A person with PBA may laugh at something that's sad or cry at something that's funny. PBA episodes can also be exaggerated from a person's true feelings. For example, they may sob uncontrollably at something that is only slightly sad. For people with PDA, the disconnect between internal emotions and external expressions can be frustrating, both for them and their loved ones. Stroke survivors have described feeling as if they're going crazy, or sometimes claim that they didn't know that they were so emotional. Pseudo.
Now, one of the things I want to make sure you heard there was the conflict between internal emotions and external expressions. And they don't have any control over it. There's not anything they can do about it. What then does it do to us as caregivers? We can get really frustrated with them, especially if we don't understand that this is part of dementia. What if they're not even diagnosed yet? Because what if there's not any memory loss? Or maybe the memory loss is really mild, but we're seeing the disconnect. And that's the key word. It's a disconnect between what's going on internally and what's coming out externally. And it's all a part of vascular dementia. That particular, the pseudobulbars, it can be treated. There's medications that help with it. Now, the first video we watched talked about the types of vascular dementia. Each of the dementias, most all of the dementias, has its own little umbrella, and there's types of vascular, there's types of frontotemporal dementia. But we're going to look at 3 types of vascular dementia. The first one we've already mentioned, and it is mixed dementia. It's when vascular dementia coincides with another type of dementia, the most common being Alzheimer's disease. So this is a great graphic that shows this is a particular brain that has that amyloid plaque on it. It has the tangles in it that we know cause Alzheimer's disease. Those things contribute to Alzheimer's. Alzheimer's then is the reason for dementia. But this person has had hypertension and diabetes also. Untreated or undertreated hypertension and diabetes, they then develop dementia and they've got both vascular and Alzheimer's disease. The next type we're going to look at is the subcortical vascular dementia. It has another name, and it's called Binswanger's disease. Another really interesting type of vascular dementia if you are interested in studying the brain. In my entire career, I have known a handful of residents, patients, clients that had Binswanger's. It is very interesting, and we're going to watch about a 2-minute video on it as well. There's all kinds of things that you can find out there about vascular dementia as the research goes into it. But what's happening with this particular type of dementia, this is one that has to do with those small blood vessels. And these are deep, deep within the brain. And what happens, you can see it here on this image. The walls in the brain get very, very thick. They become stiff and they twist. You can look at that image there, and even if you're not someone who works in healthcare, you can probably look at that and think, that just doesn't look quite right. Look how thick the walls are in that brain. This is what Binswanger's disease looks like. It causes damage to the brain's white matter, and that's the deep tissue of the brain. So a person with Binswanger's can have some unique symptoms. And this all falls under vascular dementia. Again, we're going to watch just a couple of minutes on this.
Today's topic is Binswanger disease. Binswanger disease is a progressive form of dementia caused by widespread microscopic areas of damage to the blood vessels that supply the white matter and affects the deep structure of the brain. The white matter is found in the deeper tissue of the brain. It contains millions of nerve fibers that connect other parts of the brain and spinal cords and carry nerve impulses between neurons. Many of the nerve fibers are protected by a fatty material or sheath called myelin, which gives white matter its color. Myelin also protects the nerve fibers from injury. Any damage to the white matter causes the myelin to break down, resulting in problems such as delayed memory or mental deterioration. This progressive neurological disorder develops after age 60 and increases in severity with age. This disease is also referred to as subcortical vascular dementia. While many dementia results from damage to the cortical portion of the brain, Binswanger disease and some other diseases such as Parkinson's disease, Alzheimer's disease, Huntington disease, and dementia associated with AIDS result from damage to the subcortical areas of the brain, especially the subcortical connections. Causes: Binswanger disease is caused by atherosclerosis and thromboembolism and other diseases that cause an obstruction to the blood vessel supplying the deep structures of the brain.
So that gives you an idea what's different about Binswangers. You kept hearing him use the term, and I had used the term, the deep structures of the brain. One of the unique symptoms of Binswangers that I've seen myself is it is not uncommon for a person with Binswangers to develop a grandiose personality in somebody who maybe never was grandiose. They also tend to use a lot of confabulation. Now, keep in mind, there's a difference in confabulation and an outright lie. So somebody who has Binswangers or any other type of dementia, but especially when I may see it in Binswangers or other vascular dementias, because they do still have the ability to communicate, they want to be able to be social. So their brain will confabulate a story to be able to be part of a conversation. One in particular that I can recall was a gentleman with Binswangers who would come into my office very often and tell me stories of being in the Army and the Navy and the Air Force. But he was never in the Marines because he didn't like the Marines. And his son would come in and tell me how his dad was lying because he had never been in any branches of the military. Well, was he lying? No, he was confabulating. He was telling a story. He was trying very hard to be social and to tell stories. So confabulation was part of his disease process. So make sure that you heard there what's different about Binswangers. It's that deep, the damage very deep in the brain. The other one, multi-infarct dementia. This is the one, it says more common than single infarct dementia as a result of a series of mini strokes. So this is the one that ties back to those TIAs that we mentioned earlier. And we're going to look at a picture of some TIAs. TIAs themselves last no more than 24 hours. Sometimes after a TIA, a person will be very sleepy. I have heard it even worded that it's like they almost have to sleep it off. They become drowsy. They're confused. They may stare off at something for a while. They sleep really, really deep sleep. And it's kind of like they come out from under a fog, but there's some damage done. And it can show up in really subtle ways. And they'll tend to have the TIAs over and over and over. Well, what happens with that TIA is then there's dead tissue. That then failed blood supply to the brain, which leads to vascular dementia. So these are some actual brain scans. As you can see in A, the one in the top left, that's a pretty big stroke. It's pointing right to it. And then I want you to look at B. It's also pointing to an area, but there's a dot almost, and C and D pointing to what many times is referred to as a pinpoint stroke. Just boom, it's right there. So look at C. The damage in this person's brain is right there where that arrow is pointing. So if we look at them, the only place they're going to have damage is in that area. So are we likely to catch it, see it, or even think that it's dementia? Depends on what's going on in that area. Depends on what that area controls. But this gives you an idea that as a person develops more and more of those pinpoint strokes, we start to see it. One of the examples that we use a lot, Jamie and I will talk about, if you could imagine a Christmas tree and all of the lights are on, but one light goes out. We just turn the tree so you can't see that light. But then another light goes out, another light goes out. You see where we're headed. And eventually there's so many lights out that you notice. And then the whole tree begins to dim. And what we like to say is eventually the family then, we, the caregivers, become the light. We become the light of the tree. So some of those causes, again, of vascular dementia. Keep in mind, the reason a person develops vascular dementia is because they are not getting enough nutrients and oxygen to the brain. And then those blood vessels in and around the damage become damaged. So you can see on that scan that we showed how, okay, the damage is right here, and then the area around it becomes damaged. And so that area begins to die. So let's talk just a minute about stroke, since it is the most common cause of vascular dementia. A large stroke can suddenly destroy brain tissue. That's why vascular dementia is one of the few that can come on suddenly. Then, going back to the TIAs, the little small strokes, that can accumulate over time. So it can appear suddenly, or it can worsen in steps. So let's look at a graphic. What's actually going on in the brain? If a person is building up plaque in the brain, let's say that they have high cholesterol, or there's diabetes, or there is high blood pressure, anything that is impeding the blood flow to the brain. Now, with a stroke, though, there's that blood clot. And what happens? You can see what's going on there in the graphic, and we're even going to look at different types of stroke next. If we think for a moment that someone is having a stroke, we want to assess them, look at their face, look to see if the face is uneven. Ask them to put their arms directly out in front of them, because typically they're not going to be able to. One arm's going to be higher than the other. Ask them to speak and see if their speech is slurred. And another one I'm going to throw in here under S is smile. Ask them to smile and see if they can smile. And then I'm going to throw one in under T, because definitely T is time. We want to call 911. But another thing we can do when we think someone's having a stroke is ask them to stick out their tongue. Ask them to stick out their tongue. It is not uncommon for a person who's having a stroke or who's just had a stroke. You tell them to stick out their tongue, and they either can't or they'll do something like smile. They won't be able, they know I'm supposed to be doing something here, but they're not making the connection. So let's look at another graphic of this stroke and types of strokes in the brain. So we've talked about that TIA, the little small strokes, but there's ischemic strokes and there's hemorrhagic strokes. And we're going to look at each of those. Again, not everyone who has a stroke is going to develop dementia. There can be symptoms such as paralysis, numbness, confusion, headache, trouble with vision, a metallic taste in the mouth, a difficult time swallowing. I even saw someone one time who was having a stroke who was going like this. First of all, there was a taste in their mouth. And the second thing was they were having a very, very hard time swallowing. This is very common. And then trouble walking. So let's start with the ischemic stroke and what's happening. This is when there's a blood clot or there's some other type of blockage. And so there's an obstruction to the blood flow to the brain, and then there's a stroke. The next is a hemorrhagic stroke. This is when a blood vessel in the brain actually ruptures and it bleeds into the brain. This can lead to very serious neurological damage and serious disability. A person who has a hemorrhagic stroke has about a 50-50 chance of living. It is important that if we think someone's having a stroke, that we get them to an emergency room right away, because we can't tell by looking at them what type of stroke they're having. There's going to be a physical exam, a blood test, a CT, an MRI, an ultrasound, where they're going to check the carotid arteries. So some things that we can do to prevent stroke. This is stroke particularly. First is diet, making sure that we change our diet. There is a diet called the DASH diet, DASH, DASH diet. It is specifically made for people with high blood pressure, hypertension. Exercise, at least 150 minutes a week of exercise. And you can break that up any way that you want to, but a minimum of 150 minutes a week. Controlling those things that we've mentioned throughout the course of this program: diabetes, cholesterol, high blood pressure. And we have control over alcohol, smoking, and drugs, because that's something that we choose to do. Diabetes, cholesterol, and blood pressure. Now, if your loved one or you have been on the same medication for a long period of time, it's probably time, because you've aged. Has your weight gone up or down? Things change. So maybe it's time that we either add a different med, or they've come out with new medications since then. So the medications include things like anticoagulants, clot dissolvers. There are surgeries that can be done, like stents and angioplasties that can clip aneurysms. There are things that can be done to treat stroke. In the nutrition, as far as that diet goes, the number one thing we want to do is to limit salt. We really, you can find research and arguments on both sides of red wine. There's an awful lot out there right now that says no alcohol is what's best. Because for the longest now, oh, no, one glass of red wine. I found an awful lot this week that I was looking at that said, just don't do any. Watching our sugar intake, making sure that we're getting the fruits and vegetables, the whole grain, the lean protein, and low fat. Now, some of you may also be thinking this sounds a lot like Mediterranean, and it does. This sounds a lot like the Mediterranean diet. So we've talked about stroke. Next, let's look at small vessel disease. This is when, and this is an actual diagnosis, small vessel disease. And what's happening in small vessel disease is that the little teeny tiny blood vessels that are deep in the brain become narrowed, or they become damaged. This is very common in people that have had long-term high blood pressure, and they either didn't even know that they had it, or it was poorly controlled. And this damage is taking place in the brain, and they don't even know it. That is why they call it a silent killer. Because a person may just think that they're having occasional headaches, and what's actually going on is damage, just like this. Because look what this says: it leads to gradual loss of thinking speed and planning ability. This one doesn't happen overnight. This comes on gradually. And then there's chronic reduced blood flow. Let's think about what this one is. This is from heart problems or circulation issues that's limiting that oxygen delivery. The brain tissue becomes vulnerable to injury. We see this a lot in somebody who smokes. There's a circulation issue. It's not carrying oxygenated blood to the brain. And then there are the mixed brain changes that can happen. This is when someone has vascular damage plus a neurodegenerative issue such as Alzheimer's. And again, that's where we get that mixed dementia. Some other things that we can do to protect our brain. Again, we've mentioned diet, we've mentioned exercise. In the very first video we watched, we saw somebody out there and she was working on her pill box. If you've been prescribed medication for any cardiovascular, high blood pressure, cholesterol, diabetes, we have to take it as it's prescribed. And I know that I'm speaking to caregivers who sometimes don't take their own medication as it's prescribed. because you're so busy taking care of someone else. We have to take our medication as it's prescribed, not cut it in two so that it will last twice as long, but take the medication as it's prescribed. If you have sleep apnea, I understand that wearing a CPAP is not always comfortable. I wear one myself. I have for over a decade. But now, when I don't need it like I used to need it, I'm so used to using it that I sleep better with it. It's worth learning to sleep with that CPAP on when you understand the damage that's happening to your brain if you don't use it. Maintaining a healthy weight is very important as well. And then let's talk for just a minute about general anesthesia. We want to avoid general anesthesia as much as possible. General anesthesia is damage to our brain. Think about what's happening. Now, general anesthesia is the anesthesia where you are intubated down the throat. This is not twilight anesthesia in the back of the hand. This is general deep anesthesia for something like a knee replacement, a hip replacement, a big major surgery. Now, sometimes it's unavoidable. We just have to have it. That's when we've got to be an advocate for ourselves and an advocate for our loved one and talk to the anesthesiologist, tell them that you are concerned, and ask for other types of anesthesia. I had a knee replacement with a femoral block. Now, I still had general anesthesia, but I had less for a shorter amount of time because I had that femoral block as well. You don't know if you don't ask. So talk to the anesthesiologist, tell them your concerns, and discuss different types of anesthesia. Some other risk factors, and most of these we've talked about, but let's just review these. So we've got the sleep disorders. What about low physical activity? If we are leading a sedentary lifestyle, 150 minutes a week. Well, how do we break that up? Are we going to break it into 30 minutes at a time? 15 minutes at a time? Could we do 10 minutes at a time in a week? There's the stroke. There's genetic factors that play into this, and you can actually be tested for cardiac genetic factors. Ask your doctor about it. It's a blood test. There's also a test that is a swab in your mouth. That's a genetic test. A person's sex and age. The older a person is, the higher our risk. We do tend to see more females with dementia than we do males. Women live longer than men on average. Our diet, diabetes, there's the cardiovascular risk factors again that have to do with hypertension, high BMI. Psychological factors we've discussed, depression, the changing of the brain chemicals, and it changing permanently. Smoking and alcohol is on there again as well. So let's talk about depression. Depression and anxiety are the most common mood disorders in the United States, but there is such a stigma to depression and anxiety because it falls under a term that I don't even like to use. And I am a licensed professional counselor, and I don't talk about mental illness. I talk about brain health. Brain health. We talk about heart health with no problem. Why don't we talk about brain health? Only a third of the people who have depression or anxiety are receiving treatment. That means that 2/3 are not. And anxiety and depression actually damage the brain because of the chemical changes that happen in the hippocampus. And the hippocampus is the memory center of the brain. Another area that gets damaged with depression is conflict resolution, the prefrontal cortex of the brain. This is executive functioning, this is planning, all because we are not treating depression. 80% of the time, depression can be completely cured. 80% of the time. And 100% of the time, we can treat symptoms, even in treatment-resistant depression. We can treat symptoms. Why wouldn't we do that? We've got to remove the stigma associated with depression. So how does one get diagnosed with vascular dementia? We mentioned earlier that there's going to be snapshots. So when someone goes through neurocognitive testing, that's going to measure brain function, and that is going to be a snapshot of that moment, what's working and what's not working. When someone does a neuropsych testing, it's usually 3 to 4 hours, and it's going to test memory loss, attention, processing, executive functioning, and language. There's also going to be an MRI, there might be a CAT scan, there might be a PET scan that can show a stroke or show a bleed or show an aneurysm. Life expectancy. Again, this is a statistic, so keep in mind there's somebody on this side of it and somebody on that side of it. If a person develops vascular dementia before the age of 65, life expectancy is about 3 years. It's shorter than other types of dementias because there's the direct correlation between the heart and the brain. And so this vascular dementia is because of a cardiovascular issue. If it's developed after the age of 65, average life expectancy is 5 years. Most people with vascular dementia will pass from a heart attack or a stroke. It's fairly rare that a person with vascular dementia goes all the way to the end stages of dementia, like you might see with Alzheimer's disease, where they are complete and total care patient, because usually they will have had a heart attack or stroke before that. Life expectancy is lower because of those vascular issues, those underlying vascular issues. So there are no medications specific to vascular dementia. However, there are medications for most of the symptoms of vascular dementia. That's really what we're doing with all of the dementias anyway, isn't it? We're treating symptoms. We also, this is what we've stressed in this program, we control risk factors. We control the blood pressure, the cholesterol, alcohol intake, smoking, obesity, diabetes. So we control the risk factors. And the Alzheimer's Association has a study that has shown that there is substantial evidence that if we treat the risk factors, it improves the outcome. It can also help postpone or prevent further decline. So we don't want to think, well, it's too late. I smoked for 40 years. Is there damage done? Absolutely, there's damage done. But can we today move forward with the diet, the exercise, the socialization, the making sure we're taking our medications the right way, sleep, brain games, all of the things that we know to do? Of course we can. We just have to decide to do it. Prevention, again, to review, control those vascular risk factors, staying physically active for at least 150 minutes a week. I was at a program earlier this week where this was a gentleman who had his doctorate in physical therapy, and this 150 minutes a week has been out there for a while. Eating for vessel protection. This is another diet that I put on. I mentioned the DASH diet earlier. This one is called the MIND diet, M-I-N-D. MIND diet was created by neurologists specifically for the brain. It has 10 do's and 5 not so much. It doesn't even have any don'ts on it. 10 do's and 5 not so much. Look it up, the MIND diet. Avoid smoking, limit alcohol, protect your sleep, and stay at that healthy weight. Here's our information at the West Center. I'm going to stop sharing my screen so I can see if we have any questions that I can answer. I know that Jamie was answering questions for a while. You will receive the slides. You will receive a copy of this program. And let's see, my phone. Could you email? Yes, she's going to email everybody the slides. and a copy of the program. She put it in for a while. Who do you see for treatment? You can start out at a primary care physician. Most of the time, with all of the dementias, we're going to start at primary care. Let primary care run all those blood tests and do the tests that they can do. They then are very likely going to send you to a cardiologist. If it is something that they believe is vascular, they may send you to a neurologist. They may send you to a geriatrician. But we want to start at primary care. Is someone with rheumatoid arthritis will develop vascular dementia? No, not necessarily at all. Rheumatoid arthritis doesn't fall under a cardiac condition. So a person with rheumatoid arthritis, that doesn't necessarily fall under the dementia umbrella. Now, everybody could be at risk, but does that fall under the umbrella? It does not. Information. Good. Very good. Very good. Does anybody else? We've got about 90 people on. You can type in the chat. Talking about Binswanger disease, you mentioned a personality change that I missed. It was right before you talked about confabulations. Yeah. Becoming grandiose. Yes. A person with Binswanger sometimes becomes grandiose, where I'll give you another example of becoming grandiose. This was the same gentleman who told me he was in the Air Force, the Army, and the Navy. He would come in and look at my wall behind me, and he'd count my degrees on the wall, and he'd say 1, 2, 3 degrees. I've got 5. And I would go with him to his world. Tell me about your degrees. I've got 2 PhDs in chemistry and physics because they're the easiest. He'd never been to college. He was grandiose. He was telling big stories, big confabulations. Now, where his son again was the one going, he's lying. I said, he's not lying. He's finding a way to have a conversation. He's finding a way to have a conversation. Just go with it. I sat on that man's bed as he was passing, and I told him back our stories that we created together because we created a bond. It was our connection. The name of the medication used to treat the emotional incontinence. I didn't say the name of the medication. I don't think they say the name of the medication in the video. That's something you can look up. When you get the slideshow, Misty, you can watch the rest of that video because I cut it off at about 2 minutes and check it out in there. But I also know I see commercials for it all the time. Why give a person with vascular dementia memory meds? They usually start everybody on those memory meds, which is the Aricept, the Namenda, the Exelon, just to see, is it going to help at all? Because even with Alzheimer's or Lewy body or frontotemporal, we're taking a chance. Is it going to work? It works in some people, it doesn't in others. It gives some people diarrhea so bad they can't take it. Other people have some pretty good luck with it. So 9 times out of 10, they're probably going to prescribe the Aricept and just see if it helps. Absolutely. Glad everybody was here. Again, this will be on our YouTube tomorrow, but you will get a copy of it. You'll also get a copy of the slides. You'll know where to find us and reach out anytime. Appreciate you being here. Look for you again soon.